Yeah. So, hello, everybody, and welcome. Thank you for joining the Marfan Foundation and its divisions for our 2026 Global Virtual Conference session. And this one, as you know, is on if you were diagnosed with Stickler as an adult, now what? So, this really emanated from a Facebook group that you guys all have, and everybody was talking about how so much information about Stickler is for children, and adults need information too. So here we are, and we're fortunate enough to have Dana Goodloe here. She's a genetic counselor at UAB in Birmingham, Alabama. And with us also behind the scenes is my colleague Meredith Mishner, who's going to smooth things out in the back. You might see her in the chat as well, providing some links that are valuable for you during this session. Before we start, I want to let you know that we are recording this session, and it will be on our YouTube channel afterwards so that you can watch it and other people can watch it who are not here live. I also want to point out that if you have questions during this presentation, please put them in the Q&A box, which you'll see. If you don't see it on your taskbar, click more, and then you'll find it there. And there is a chat, and of course, you can chat with each other, chat with us, tell us where you're from, chat during the session. But for any questions and answers, please put them in the Q&A box because that's where we're going to look to after the session, so we can ask the questions. Through the chat, we might miss them. So anyway, thank you for being here, and thank Dana. And with that, I'd like to turn it over to her to share her slides, and we can start the presentation.
All right. Let me get my screen shared on. 1 second. All right.
Looks great.
Like she said, I'm Dana. I'm a genetic counselor at the University of Alabama at Birmingham, and we are kind of an interesting department in that we cover both pediatrics and adult care. And so our physicians that work with us, many of them are trained as pediatricians and then go on to do a genetics rotation or a genetics training kind of in addition to their pediatrics. But we do have several that are actually internal medicine trained and do adult medicine. So our kind of viewpoint and perspective on things can be a little different from other genetics groups because while we certainly take care of a number of kids, and especially a number of kids with Stickler syndrome, we do have adult care that we offer as well. So my particular specialty with Stickler is more in the pediatric realm, but I have kind of been able to adjust some of my experience and work on the adult side and have been working closely with our adult medicine providers to make sure that we're covering everything that we needed to go over. So a couple of things I want to go over today. I do want to do a couple of basics, just talking about the natural history of Stickler syndrome and understanding collagen disorders in general, and then we'll get into more of that medical management and kind of go over some specifics. So when we're thinking about kind of the basics, what is Stickler syndrome? This is a genetic disorder that impacts the connective tissues, and those can be any variety of connective tissues throughout the body. Most individuals have a single pathogenic variant in one of the common collagen genes. There are some that have two pathogenic variants or two mutations for those recessive disorders, and we'll kind of talk about the difference in those. But one of the things that makes Stickler syndrome kind of more difficult when you're thinking about diagnosis is it is incredibly variable, and that's going to be both within and between families. So the same genetic variant is not going to produce the same features in every individual in the family. So oftentimes we do have a child that may have more significant features that's getting the diagnosis that then leads to us finding out that other family members have that diagnosis as well. And so we may be diagnosing multiple generations based on one individual's presentation, but those individuals can have very different progression of disease and very different phenotypes or presentation depending on kind of their specific body. And we don't really have a way that we can predict what they may or may not have as far as their features based on their particular genetic difference. So I'm going to go over kind of some of the common areas and kind of dig into these a little bit more for each kind of body system that it affects. But really, these are kind of the four main areas that we're thinking about. So the eyes, the ears, the joints, and then the face or palate, kind of lumping all of that together. And so you can see a couple of very specific abnormalities that we associate with Stickler syndrome. Many of these are common in the general population, but can be more common in individuals with Stickler syndrome. So things like degenerative joint disease or joint pain, these are going to be very common in the general population, but are going to be more common in an individual who has Stickler. The other things listed under joints, those are a little more targeted. And so if you had radiographic or x-rays done and we're seeing these specific abnormalities, I do have a typo on that slide. I apologize. It's supposed to be like changes in the hips. But if you have any of those can be things that are more specific for Stickler syndrome, but are still not going to be diagnostic of Stickler syndrome just by themselves. So having something like a retinal detachment doesn't guarantee that you have Stickler syndrome, but certainly individuals with Stickler syndrome are at a higher risk. I put together this graphic with some assistance from everybody's favorite ChatGPT of just thinking about what are all of the different body systems that we should be worried about and how are these presenting for those individuals. So this is kind of just doing a head to toe check of everything that we can think about. A lot of that is going to be like Eileen said, things that are cared for in that childhood or even newborn period. But some of these are going to be things that can affect us lifelong. And so when we're looking at our eye differences, myopia or nearsightedness is something that's super common. We usually think about that being a more severe progression. So anything above -3 is considered to be a higher prescription and a higher severity of myopia. Those retinal detachments, like I mentioned, and then the vitreous abnormalities. So those are just kind of specific things when the eye doctor is looking at the back of the eye that they can see changes in the way that everything is connected, and they can kind of tell that there's differences there. There's a couple of specific things that they're looking for. I try to leave some of those specifics to the eye doctors themselves and let them describe those. But even things like cataracts and glaucoma, which again are common in the general population, we're going to see those at a much higher rate in those families with Stickler syndrome. And so sometimes these things can go undetected to be related to Stickler, just because they are more common things that we can see. For individuals that have these genetic predispositions for things like cataracts or glaucoma, oftentimes we're seeing those at younger ages than what we would see in the general population. So if it's super common to see a cataract in somebody in their 60s or 70s, we could even see those in individuals in their 30s or 40s if they have a diagnosis like Stickler syndrome. And so getting that routine care and making sure that you're following with someone who knows about the condition and knows what you're at risk for is going to be super important. Thinking about hearing loss, this could be both a sensory neural or a conductive hearing loss, and I'm going to dive into those a little bit more in a minute and kind of talk about the distinctions there. Many of the palate or jaw differences are likely going to be managed in childhood, and so not something that's going to be super impactful in adult medicine, similar to the kind of dental crowding and things like that. A lot of that's going to be handled by the time you're getting into adulthood. Joint pain and joint instability are going to be a common thing that a lot of individuals with Stickler syndrome are facing. And this is where we're going to see a big impact in adult medicine, just like the eyes. As we get older, those are progressing more, and so those can become more symptomatic for an individual as they continue to age. I wanted to kind of break those down a little bit more, and so put together this visual as well, just kind of walking through some of those. I don't love this visual as much because especially under the facial features category, the face they show does not have any of the characteristics that they are showing. It's just saying where on the face those characteristics would be. And so a kind of underdeveloped mid face would show like a reduction across here where we're not seeing that nasal bone quite as prominent. And so it can have much more of a regressed or flattened appearance here. The way I like to think about it is if you were to take a piece of paper and hold it up in front of your face and put it on the tip of your nose, where else does that piece of paper touch on that individual's face, and what's that spacing look like? So somebody that has a really underdeveloped flat mid-face, that piece of paper may also touch at their brow. It may touch closer into their eyes or even on their mouth because there's more underdevelopment across here. And so that picture, not a great representation, but is showing you kind of where on the face that development would be. And then it's really hard to assess the size of a jaw from a front-facing view, much easier to assess those from a side-facing view. But again, if you think about it kind of like a straight line going down the front of your face, an individual with a smaller jaw that may have more of a recession, that may be pulled back a little bit more, and that can even affect where your ears are on your face. And so sometimes it can have the ears being a little bit lower set than what they would be in the typical population. When thinking about facial features and things like this, I like to tell patients everybody has unique facial features and everybody has something that's a little bit unique with the way that their face is oriented. There's nothing necessarily wrong with any of these. They're just describing what doctors are seeing, and we're seeing those different features in those individuals. And so we're seeing these more commonly in individuals with Stickler syndrome than in the general population. But all of these are things that can be seen in the general population as well. So I always like to point that out. As geneticists and genetic counselors, we're trained to look for these things. The general population is not looking for these things. And so they're often things that other people wouldn't even notice or pay attention to. But when you're coming in for genetics evaluation, they are things that we look a little bit closer at. One area that wasn't addressed earlier is that there can be some cardiac issues that we see. Usually those are fairly mild and can be something like mitral valve prolapse. Again, this is something common in the general population, but at a higher frequency in individuals with Stickler syndrome. And then things like aortic root dilation. So a little bit of an enlargement there. So we often do recommend that cardiac referral. You'll see information about short stature. That tends to be some of the other collagen disorders and not as often with a kind of classic Stickler syndrome presentation. But there are some that can have just slightly lower stature than what we would have expected based on their kind of average parental height. So I mentioned that there's about 6 genes. Some can include a 7th gene. I like to include that 7th gene just because I have a patient that we recently diagnosed with that. But we kind of break it up into 2 different categories, those autosomal dominant conditions and then those autosomal recessive. And so you'll see collagen 2A1 or col 2A1 and col 11A1. Those are going to be the 2 most common forms of Stickler syndrome or genetic causes of Stickler syndrome, with 2A1 being about 80% of individuals and 11A1 being about 20%. 11A2 is a much more rare, but still can be seen as a dominant condition. And then those collagen 9 abnormalities are a recessive form. So for the dominant condition, those individuals have one harmful difference in the collagen, in that specific collagen gene, whichever one they have. So when we think about our genes, we get 1 copy from our mom, 1 copy from our dad, and those are packaged into pairs called chromosomes. And so for most of the genes in our bodies, we're going to have 2 copies of that gene, what we call different alleles. And for a dominant disorder, only one of those copies has to have a harmful genetic difference or pathogenic variant to have that diagnosis. For a recessive condition, both copies of that gene need to have some type of harmful difference. It doesn't have to be the same harmful difference. In fact, most of the time it may not be, but both of those copies would be have that difference. And so the parents would then be carriers of the condition, but not affected with the condition. Whereas in the dominant disorder, the parent is typically affected, or that individual is a new variant, what we call a de novo variant in that person. So they may be the first person in their family to have that. With a condition like Stickler, because that variability, it is so important to test parents and not just assume that that child is the first person in the family. I've seen several cases where they were, but I've seen several cases where we expected it to be de novo and it ended up being that one of the parents was positive and they were just very mildly impacted by that diagnosis. So this is a graphic kind of talking through inheritance. For this particular example, this is showing an affected father. This is a condition that the biological sex of the individual does not come into play when thinking about the chances to be affected with the diagnosis. So either mother or father being affected, they are each going to have a 50% chance to pass that on to all of their kids, regardless of their biological sex. And so every time that man is having a child, he's going to have a 50% chance to pass that on. It's not going to be dependent on the previous child that he had. So if his first child is unaffected, it doesn't guarantee that the next one will be affected. It's going to be a new 50% risk each time. And the same would be true if it was a female that was affected. This is showing that recessive inheritance where we have our parents both being carriers. So each of them has one working copy and one non-working copy. And so they have a 50% chance of passing on each of those, which gives us that combined risk of a 25% chance to have an affected child. So that chance that both of them would pass on their non-working copy is going to be 25% or 1 in 4. Like dominant inheritance, this is going to be an individual risk each time that couple has a child. And then if they have children with other partners, their risk to have an affected child will be dependent on whether or not that partner was also a carrier. So that's something to think about for those recessive forms. So what is collagen? Many of these genes start with that COL and they are coding for some type of collagen. So what is collagen? This is just a type of protein that is in our body. We have tons of different proteins in our body. This is one of the more common ones, and it's used to provide structure or support within our cells and within different parts of the body. So within skin, muscles, bone, ligaments, all of those types of things. I kind of like to think about collagen almost like the rebar in a building. So if we are building a building and we have our concrete blocks that we're stacking up, they put those rebar holes in the middle of those to help make sure that they have some extra support. They're pretty good by themselves with just those cinder blocks. But if we add in that metal support in the middle, it just gives it that little bit of extra strength and extra support that if the wind starts blowing that building pretty hard, say we've got a hurricane coming through, it's going to hold it up a lot better than if we didn't have those there. The collagen's kind of like that. It's giving that extra support, that extra structure. And it's found in all different types of connective tissues. And there's a number of different types of collagen. So you'll see information about like collagen 1 through 5 being the most common. Obviously, they were the first ones described. But as you can see from having something called call 11A2 or 11A1 or 9A1, there's all the way up to, 11 plus different types of collagen that we can see. And those different types of collagen are going to be used in different parts of the body differently. So type 9 and type 11 are much more heavily used within the ears than type 2 is. Type 2 is much more common in the joints and in the eyes. And you'll see that when you look at the distribution of those presentations. So if we look at the rate of something like a hearing loss, it's much higher in those patients who have abnormalities in 11A1 or 2 or in the collagen 9 genes than compared to those in the collagen 2 abnormalities. And that's just because that collagen 2 is not as commonly represented in the ears as it is with collagen 11 and collagen 9 in the ears. So that rate of hearing loss is much higher. But you can see for the collagen 9 disorders, clefting is not typically reported for those individuals because it's not as commonly present in those palatal and facial structures. So you can see the eyes and the ears much more significantly impacted for those collagen 9 kids, whereas in those collagen 11 and collagen 2 disorders, those numbers are a little bit different. You can see for the palate abnormalities, there's not a lot of distinction between collagen 2 and collagen 11 defects. Same for the rate of myopia, it's about the same. But that hearing loss becomes a big difference, and that retinal detachment becomes a big difference because collagen 2 is much more prevalent in the eyes than collagen 11 is. And so it helps to know exactly what gene your family has to then be able to know what your chances are for each of these different types of presentations. We still want to check all of these for everyone and make sure that we're not missing anything, but this can kind of guide us to say, oh, I'm in a higher risk category for a retinal detachment, or I'm in a higher risk category for a hearing loss. I need to be really thorough with making sure I'm keeping up with my eye exams or keeping up with my hearing tests, things like that. So one thing to also think about is who in the family has actually had genetic testing and who in the family still needs genetic testing. So if your child has been diagnosed with Stickler syndrome, we're going to say they have a collagen 2A1 variant, that most common gene, and you have a history of high myopia, do you need genetic testing? What is that going to do for you? For most people, they are going to need their own genetic testing report, even if a family member has already tested positive. And that's just to prove that you have that diagnosis, and we can say, here's this genetic test result to prove this. The reason for that is often insurance coverage. Insurance isn't going to want to cover all of these extra medical appointments or extra screenings or extra things that you need for your health if they don't know why you're being seen for those different evaluations. And so if you can get that genetic disorder diagnosis on paper, now we can say, okay, you have this, confirmed molecular diagnosis. We can cover those services for you. Depending on what lab did that original patient's testing, they may offer free family variant testing. And so that's something to talk with your genetic counselor about. Or testing is often at a reduced cost. So whereas ordering a large panel of all of the genes associated with Stickler may be a couple $1,000s to your insurance company, you may have an out-of-pocket cost of a couple $100 depending on what your coverage is. If you're doing targeted variant testing, that may only be $100 for both you or your insurance company, whichever one is covering the cost of that testing. So certainly inquire about those testing options to see if we can utilize that free testing when available. For a lot of institutions, they are going to require that each individual has their own appointment and their own medical record. And that's just to have documentation to say, this is a patient that I'm caring for. And if they come back positive, I'm going to be able to manage these results. If you are not our patient, we cannot take care of you and make medical management recommendations for you. So if we have diagnosed a child at our pediatric hospital, we can't then just automatically order testing for their parent. We need to get them referred to our adult clinic so that they can be established, get their own chart, get their own appointment, and then be able to go forward from there. For our institution, we try to coordinate these as quickly as we can, especially if we're trying to utilize that free testing option, because those labs do often have time parameters on there of we'll offer free testing for the first 180 days after an individual has been diagnosed. Now, sometimes they'll be a little more flexible if you reach out and ask, but not always. So we try to get those in as quickly as we can. But that's just kind of a great next step to think about. Once we've got the diagnosis in the family, where do we need to go from there for making sure everybody else gets their confirmation? And then how high do we need to go? If my child has been diagnosed, now I've been diagnosed, now we need to go up to the next generation. My parents need to undergo testing. My siblings need to think about testing. So it really starts to kind of ripple out and expand out, and we end up seeing a number of individuals within a family pretty quickly, trying to figure out who all has this diagnosis and where we need to go with their medical management. So we've touched on a couple of these, but want to kind of put it into a more cohesive slide. And then I'm going to talk about some nuances with each of these different areas of evaluation. One thing we want to make sure we're doing is keeping up with those audiology evaluations, making sure that we're getting those routine hearing tests. For our kids, the pediatrician offers those pretty regularly for their well child checks. Once we get into adulthood, nobody's really checking our hearing anymore. So you've got to initiate that on your own and make sure that your PCP is sending you for a hearing test. We also want to get a baseline echocardiogram. So taking a look at the heart, seeing if there's anything going on, any structural differences, things like that. And then the cardiologist can make recommendations for how often you need to come back. Ophthalmology evaluations, so following with a medical doctor that specializes in eyes, particularly if they have more experience with retinal detachments, is always going to be a good idea. So you may, if you're in a larger area or have a large health system close by, kind of do some investigative work and find out who is the most experienced or the most interested in retinal disease, because you may have some that are more specialized in glaucoma or macular degeneration, but you want to find that one that's really specializing in retinal detachments or has a strong interest there. There is prophylactic surgery if you start to see some of the evidence for retinal changes, and so they can do laser therapy to try to prevent those detachments from happening. Any type of corrective lenses, whether that's contacts or glasses or even both for some individuals, they can treat that myopia, and then making sure you have an emergency plan of what to do in case of a retinal detachment. And we'll kind of go over that a little bit more in a minute. Like I mentioned, joint things can tend to be one of the most severe things for our adults with Stickler syndrome. And so making sure that we are managing their joint care, whether that's with anti-inflammatory medicines. Many of those could just be over-the-counter anti-inflammatories, but you may want to make sure that you're managing that with a doctor, just because both things like ibuprofen and Tylenol are processed in the body in different ways. And so if you have an underlying liver disease or kidney disease, they may want to recommend one or the other, or have different recommendations for how often or how much you're taking of those different medicines. And then if you are having significant joint problems, orthopedic care may be something that you want to pursue. But one thing to think about is there's not prophylactic therapy here for how we can prevent any type of joint disease. I want to talk a little bit about the difference between an optometrist and an ophthalmologist, because this is probably one of the most common questions that I get asked in clinic. So a optometrist is going to be kind of your common eye doctor. This is going to be your eye doctors that are in most eye clinics that you would go to. They have a specific degree as a doctor of optometry. So they have an OD degree after their name. So they've gone to 4 years of optometry school. So they are specifically trained in eye care, and they're going to take care of your common eye diseases or vision differences. So they can do eye exams, vision testing, prescribe glasses and contacts, some screening for higher level eye diseases, but they are really doing that kind of basic eye care that the vast majority of people are going to need. On the opposite side, an ophthalmologist, which is not only a little difficult to say, but also a little bit harder to spell. These are medical doctors. So they have gone to complete medical school, just like your primary care doctor did, only instead of doing additional training in primary care or in cardiology or in another field, they did their specialty in eye diseases, so ophthalmology. So they did an additional 4-year residency in ophthalmology. So they are able to provide medical care and even surgical care. So if they perform surgeries, they are most likely going to be an ophthalmologist. And that could be surgery for things like retinal detachments with Stickler syndrome, or even surgery for something like a LASIK procedure that people in the general population may be looking for. But they're going to do that management of more complex eye disorders that tend to have other things that go on in the body. And so they're going to be thinking about it from a full medical perspective and not just related to your eyes. So they would either be an MD, or if they went to an osteopathic program, a DO. That's where it can get a little bit confusing because we have OD and DO. But the MD and DO programs are going to be medical school. So they went to medical school, not optometry school. A lot of times somebody with Stickler syndrome is likely going to have both. They would have the person that is managing their corrective lenses, their optometrist, And then they would also have their ophthalmologist. Now, ophthalmologists could and sometimes do manage the vision prescription for their patients, but they may work in conjunction with an optometrist and let the optometrist do the contacts and the glasses, and they do kind of the rest of the care related to the eyes. The next thing I want to talk about the difference between is different types of hearing loss. So for Stickler syndrome, you'll often see it being associated with either what's called sensory neural hearing loss or what's called a mixed hearing loss. So mixed hearing loss would be both a sensory neural and a conductive. So sensory neural is something that's going to be impacting the inner ear as well as the cochlea and the auditory nerve, whereas a conductive is things that are the middle ear or the outer ear. So anything kind of blocking sound from getting in, that's going to be conductive, whereas the sound is not being processed correctly, that's going to be sensory neural. That sensory neural is usually a permanent thing that would require either certain types of hearing aids or cochlear implants, things like that to impact. Conductive could be treated very easily with things like ear tubes or cleaning out a blockage or other things like that, but may be also something that is going to require a hearing aid for treatment. A big distinction is that sensory neural is going to reduce the kind of quality of what you're hearing as well as the quantity. And so you could have reduced hearing and it's not getting through all the way. Whereas with the conductive, it's going to be strictly a volume issue. You can still hear, but it's not going to impact the clarity of what you're hearing. And so as long as someone talks louder, you could still understand them. Or if you had something amplifying the sound, like a hearing aid, you could still understand them. So thinking about those differences is important. This is kind of addressing some of these don't have prophylactic treatment. And so you want to make sure that you're trying to reduce the chances for those types of events to occur. So often avoiding contact sports that could cause some type of traumatic retinal detachment. If everything is a lot looser and a lot more prone to detach in the eyes and you're playing tackle football all the time and you're getting slammed into the ground, that's not going to be great for your chance for a retinal detachment. That's going to put you at a much higher risk. The other thing to think about is those high impact activities. You want to be careful of those so that you're trying to reduce any joint damage as much as possible. And I mentioned kind of the emergency preparedness when thinking about retinal detachments. Always want to make sure that we're aware of what those warning signs are and that we have a plan. So asking your ophthalmologist, where do I need to go if I feel like something has happened and I may have had a retinal detachment? So for our patients, we have kind of two different routes of care that we do, whether you're a pediatric patient or an adult patient. In Birmingham, we are very blessed to have the Callahan Eye Institute, which is a hospital solely dedicated to eyes. And we actually have an emergency room in the Callahan Eye Hospital. And so if you are having an eye emergency and you live anywhere within like an hour, hour and a half, most of those ophthalmologists are going to tell you to drive to the eye ER because your chances of maintaining your vision if you're getting care in the eye ER versus in a local ER closer to home that doesn't have an ophthalmologist on hand are going to be very different. For retinal detachments, maintaining your vision is really dependent on how quickly you're able to get surgery and how severe that detachment was. And so surgery is often recommended within the first 24 hours of those signs. Some of these can be very rapidly onset, whereas they can also be more of a slow progression. And so it's not going to be a, immediate, your vision goes out in one eye and everything goes black. It may be more of a slower progression. It can have that quick of a reaction, but it may not be like that always. And so want to make sure that we have a plan for where to go and what to do, and then be really conscious of any of those differences, especially if we feel like those differences are isolated to one eye. If you feel like you're having, parts of your vision that are missing and that's only on one side and one eye, that's definitely concerning that something could have happened on that side and that we're having a difference in what the eyes are doing right now. If you're having kind of those regular floaters, ever so often and it's in both eyes and it's really not that significant, you may just need to clean your contacts a little bit better, other things like that. But make sure you're talking with your ophthalmologist about what you need to be on the lookout for and where you need to go, and then have that emergency plan. I'm going to brag on the Marfan Foundation, and they did not ask me to say this, but they have great information for planning for these types of events. Our friends with Marfan diagnoses or Lowenstein's diagnoses have that risk for aortic dissection, and so they also have these emergency preparedness plans. Luckily, with Stickler syndrome, that's not something we're having to worry about. But the retinal detachments are a pretty serious thing. And so keeping all of your information up to date, whether that's via your cell phone or a medical alert bracelet or something like that, just make sure that you've got that information on hand so that you can share that with those providers when you go to, maybe an unfamiliar hospital or a new location. All right. So for joint management, one of the questions I get asked a lot is, great, joints are a problem. I know that. I've been dealing with that. But who can actually help me with my joint pain? And that's a great question. And so I've put 3 different types of physicians on here and kind of tried to outline where they are best served. I think for any of these, early and proactive management is going to be key if we want to try to delay that joint damage or prevent joint damage as much as possible. And non-surgical care can actually have more of an impact for patients than any surgical intervention would. These are very different than other joint issues where you may have a torn ligament or something like that, where surgery is your only option. This is going to be a much different approach where we're thinking about kind of long-term, how can we support joint health as best we can? So orthopedics is really going to focus more on structural or surgical management. So if you have some type of bone deformity or fracture or other things that are going to need to be addressed, they can help with that. They can also help with splints or bracing or other things, and then of course surgery if needed. But they're really going to be for those broader, more structural changes. I find them to be not as helpful in the stickler population just because not as many individuals have these overt structural differences. The ones that tend to be a little more targeted for patients with stickler would be rheumatology or physical medicine. So rheumatology is able to manage joint pain and inflammation. They are great at determining if this joint difference is a degenerative abnormality or more of an inflammatory process, and really able to target what that treatment would look like based on those. And we can see both of those in Stickler syndrome. And then rehab medicine is often a specialty that's a little bit harder to find, but can be super beneficial for this population of thinking about how do we optimize function and quality of life. So they're going to help oversee things like physical and occupational therapy, make sure our goals of therapy are really well understood, and that we have a good plan for how we're managing joint health. And really just kind of that goal of a non-surgical approach to joint health and how can we manage that joint care. So if you do have, physical medicine, sometimes called physiatry in your area, that's a great person to try to see to make sure that we're really optimizing your joint health as much as possible. And then kind of the last area of care I wanted to talk about is just thinking about care during pregnancy and kind of pregnancy planning and what that would look like. So we talked a lot about those inheritance patterns and how these are passed down through families. And so if you have the diagnosis and know that you have the diagnosis and either you or your partner is pregnant, then we want to think about what that pregnancy care needs to look like. If somebody does have something like mitral valve prolapse or significant joint issues and things like that, they may require care with a maternal fetal medicine specialist for they themselves. So thinking about their health. And so that would be with somebody who's a high risk obstetrician and can kind of partner with their primary OB to make sure that we're taking care of that individual. For some people with a genetic diagnosis, they may have more significant needs during pregnancy. So if we are pregnant and increasing our blood volume and body weight and have, shift in our center of gravity, that may put new strain on different joints and cause different joint issues. And so they may require a little bit of extra help during that time. Many maternal fetal medicine doctors do work with a genetic counselor like myself, and they can go over that recurrence risk and talk through different testing options if that's something that you're interested in. And so having that access to MFM is really helpful. When we think about testing options, we can certainly do testing prior to conception if we wanted to think about IVF. So if you know the genetic change and you know that you do not want to have a child with that diagnosis, you could do IVF and select against embryos that have the diagnosis. That's not a requirement and not something that you have to do, but is a choice if that is something that you're interested in pursuing. The biggest cost there is just IVF itself, not necessarily the genetic testing to determine which embryos you would want to transfer. But IVF coverage is increasing with different insurance companies. And so you may have options for coverage within your plan, or could have that at some point in the future. If we wanted to think about testing during pregnancy, there's a lot of new information about non-invasive genetic testing options. Sometimes you'll hear it called cell-free DNA screening. This is testing that's done just with a blood test and not an invasive procedure. That is not available currently for Stickler syndrome. I don't know what all is in the pipeline, but certainly it could be something in the future that may be screened for. There are some other disorders that are similar to Stickler that are available for that type of screening, specifically the call 11 or call 1A1 and call 1A2. So things associated with like a vascular EDS presentation. Those are things that might be available in the future to think about, but currently not available. And then diagnostic testing would be either with chorionic villus sampling or an amniocentesis. So our only true non-invasive option would be if we did have an ultrasound. Unfortunately, ultrasound has a pretty low detection rate. Some papers cite the detection rate for cleft palate as low as 2% with ultrasound. Some are a little more optimistic that they can see those things on ultrasound, saying maybe up to a 20 or 25% detection rate. I don't know that I've seen anybody with an isolated cleft palate that they were able to see that on ultrasound prior to delivery. Most of the prenatal diagnoses that I see do involve the lip, and then they're able to identify the palate difference because of the lip abnormality. And cleft lip is not something that we're worried about with Stickler, so not something that we would be able to pick up on ultrasound. Those invasive testing options, I've got kind of the timing of those here. CVS is done about 10 to 13 weeks. Amnio is done about 16 to 22 weeks. As always, any genetic testing that you're doing during pregnancy is optional. You are the person who is pregnant or your partner is, and you guys get to decide if you want to pursue any type of genetic testing. These are both invasive procedures, so they do have risks associated with that. We quote about a 1 in 1,000 chance for miscarriage for these procedures, just because we are going into baby's environment and can disrupt baby by going in there. And so there's always going to be a risk for that. They do take about 3 to 6 weeks to get those results back, a pretty similar turnaround time for both of those. Sometimes it can take a little bit longer for CVS just because those cells are a little bit harder to grow than the cells from an amniocentesis would be. And then if you chose not to do any testing during pregnancy, we would recommend evaluation after birth. Certainly in the hospital, we're going to want to do that palate evaluation, make sure that baby either does or does not have a cleft palate. so that we can ensure that we're getting proper nutrition for that individual because that's going to impact their feeding right away. And then repeating that newborn hearing screen when they're about 6 to 12 months old. And then even if all of that is normal, we would still recommend that that child have genetic testing just to confirm whether they do or do not have that. And then that can help them as they get older in planning their care. So a couple of kind of key points to take home. Both optometrists and ophthalmologists are usually necessary for adults with Stickler syndrome. Those eye and joint differences tend to be the most common features that we're seeing in adulthood. And then make sure you have your emergency plan of what you would do if you had concern for a retinal detachment. And then talk with your partner and your family about that recurrence risk and be thinking about those testing options for either future children or children you may already have or other relatives. And I can take some questions.
Great. Thank you. Thank you so much. That was really great. We do have a few questions. Maybe you can stop sharing and then we can see
Yeah,
better.
absolutely.
So we had a Stickler support group last night. So I see some of my new Stickler friends are asking questions here. A lot of them are participating as well. First question: I've heard that broadly connective tissue disorders are more likely to develop. I'm going to say this wrong: dysautonomia, POTS, and that interstitial fluid differences. What is known about this for Sticklers specifically?
Yeah, that's a great question. There definitely is a lot of information out there about dysautonomia. I've not seen it associated with Stickler syndrome specifically. I see it more with the Ehlers-Danlos syndromes and even with Marfan syndrome. I think it's certainly possible. I think, if you have concerns for that, talking with your cardiologist is important. And that's why getting that baseline echocardiogram is really helpful for those individuals.
Okay, great. Thank you. Next question. I've developed a cranial CSF leak. I understand they are more common in connective tissue disorder patients due to tissue vulnerability in the dura. I had never known about this until developing this condition. What is known about it? Are there particular issues I should bring to the attention of my silent CSF leak clinic?
I have not seen that. I would talk to your neurosurgeon. They'd be better able to say if that was related to the diagnosis or not. I think that's a great question, though, and I'd certainly talk with your neurosurgeon.
So many things come up, whether it's with Stickler or the other conditions that we cover, and not everything is associated with that connective tissue or
That's
collagen
so true.
problem.
In genetics, we often have to think about like, yes, this individual has a genetic diagnosis. What of this history is genetic diagnosis and what is just some things happen in the general population? So that's definitely a good point.
Exactly. Here's a genetic testing question. One child had genetic tests, and mom, dad, and brother were used as comparisons at a pediatric hospital. Mom and both kids have Stickler col 11A1. Should mom seek her own genetic counselor since she was not referred at diagnosis? Or she has the
Yeah.
same genetic counselor
So
as
your genetic counselor should be able to request a comparator report. And so if a parent is positive on a test, they often don't get their own test report with their name, but most of the labs will produce that for you. So if you had testing through Ambry or GeneDx or Baylor or anything like that, they will often, at the request of the ordering provider, they will get you your own report and then they could go ahead and give you that test report and you could go on and get your care. You wouldn't necessarily need repeat testing.
Okay, great. Thank you. Next question. My orthopedic doctor suggested I take collagen supplements to assist with my joints. I read this doesn't work for us due to how our bodies work or that it uses a different collagen. So, can you provide some clarification on that?
Yeah. So one of the questions is kind of if you're taking additional collagen, is that going to replace the collagen that you're not producing? And the answer is we don't necessarily know. And so a lot of those collagen supplements are going to have a variety of different types of collagen. But we don't know if your body is going to be able to process that collagen the same way as it would if it was producing it on its own. So I'd say it couldn't hurt to take extra collagen supplements, but I don't know that it's going to be a preventative or anything that's going to have a huge impact on care.
Okay, thank you. Um, I'm going to ask you this question, but I'm also going to tell people there's another webinar on this. So this
Mhm.
person is asking, what is the current literature research recommendation regarding prophylactic laser or scleral buckle in Stickler type 1? Before you answer that, I just want to plug a webinar coming up at 4 o'clock, which is in 10 minutes, with Dr. Jefferson Doyle, an ophthalmologist at Johns Hopkins, who I know he had logged on to this webinar earlier. I'm not sure if he's still here, but he has a webinar on eye issues in 10 minutes. So let's hear what Dana has to say, and then I would advise you all to go log on to Jefferson Doyle's webinar. So, any thoughts from you?
The only thing I would add is certainly defer to the ophthalmology team on this one, but there are clinical trials that are ongoing. I know UAB is a site for that, and there's a couple of other sites throughout the US where they are exploring what that looks like and kind of how that works for those individuals. And so if that's something you have a lot of interest in, I would certainly encourage you to look at those research opportunities. You can just go to clinicaltrials.gov and type in Stickler syndrome, and you can see all of the ongoing trials that are there. And I know that that one is active.
Great, thank you. Okay, great question coming up here. We hear this all the time. Is it possible, not just possible, is it probable or is it possible for people within the same family to have different diagnoses? For example, one child may have Stickler and the other one has been diagnosed with Marfan. I know everything's possible, but is it likely?
Certainly possible.
Right.
I would say unlikely. The only thing that we could see is that variable presentation. And so if you do have a child with, say, like 11A1, they could look very different. So there are some overlapping conditions. 11A1 and 11A2 have a lot of overlap with a diagnosis called Marshall syndrome. And those individuals tend to be more severely affected than Stickler syndrome, but there's a lot of discussion about whether or not that's just a spectrum. And some people are on the more severe end of the spectrum, whereas others may be on a milder end of the spectrum. But I would say it's definitely possible, but not probable. For these two conditions, those are totally different genes. And so we wouldn't expect that one child having one diagnosis would put the other family members at an elevated risk to have the other diagnosis. But I follow a number of patients that have more than one diagnosis within an individual and within a family. So it is certainly possible. You know, getting one genetic condition in the family doesn't mean you don't have another in the family as well.
So what should somebody do if they've been told, should they get new genetic testing? Should they just research
Yeah, I think
themselves? What should
making
they
sure
do?
that you've had thorough testing and determining that the testing supports the clinical diagnosis. So if you've been followed for a clinical diagnosis of Marfan, and then now we have an individual who's been diagnosed with a molecular genetic test saying Stickler, let's make sure we're getting that genetic testing and really looking at those genes and seeing which one is truly abnormal, because that's going to be the best bet to figuring out exactly what's happening for that family.
I guess especially if somebody has been genetically tested many years ago, because there's new
Right.
genes obviously all the time.
New genes, new technology, the way we're looking at the genes has changed. There's so much that's been updated. If it's been more than, 10 years or so and you don't have a clear diagnosis from that genetic testing, definitely get back in with genetics and try to repeat that.
Okay, great, thank you. Last question. I have debilitating joint pains and was diagnosed with this, I have not heard it before, arthralgia,
Arthralgia.
but nothing significant seems to show on a standing X-ray or no con or with no contrast MRI. Is there another type of scan I should look into? I'm trying to build solid medical records for Social Security.
Yeah, that's a great question. Unfortunately, I think that's probably a better question for an orthopedic doctor, or even the physical medicine doctor, just to make sure that they're doing as much as they can to figure out what's going on. One of the downsides for a lot of these is that we don't get radiographic evidence of what's going on with your joints, but that we know that because they are weaker, there's going to be extra pain there, but it's not something that's going to be clearly evident on that imaging.
Great, thank you so much. I want to thank everybody for joining today. In addition to Dr. Doyle's talk on eye issues in 5 more minutes, tomorrow night we do have a webinar featuring Dr. Stephen Gowdy, who's the head of otolaryngology at Old Dominion University, has a lot of expertise in Stickler and experience. He's also the president of the American Cleft Palate Association, really a big champion for Stickler syndrome. So that is 7 o'clock tomorrow night. So please feel free to join that one as well. I want to thank Dana. If any of you have questions that pop up now or later tonight about this, please go to our website, marfan.org/ask, and a member of our Help and Resource Center, led by our nurse, will address those questions for you. Again, this was recorded, so you can watch this again or share this with others. And hopefully you get a lot more out of this conference. Don't forget, we also have a Stickler Syndrome support group the first Wednesday of every month, and that can be found on our website too. So thank you all. Thank you, Dana. Really appreciate your interest and participation with the Marfan Foundation. Really, we're really learning a lot from you and your colleagues at UAB.
Happy to help you guys.
Thank you so much. All right. Bye-bye, everybody.